morning everyone. My name is Dr. Vicky Gadwal. I am working as an assistant professor in UNMICRC Institute of Cardiology. Today we are going to discuss about coronary hardwares. We will discuss this topic under following subheadings like history, classification, catheter structure and materials, femoral catheters, radial catheters, IMA and bypass catheters, guide extension and microcatheters. First cardiac catheterization was done by Werner Fossmann through his own antecubital vein, and he went up to the pulmonary arteries. First selective coronary angiogram was an accident by Dr. Masson Sons. While doing a ventrogram, he accidentally cannulated the RCA unknowingly. Diagnostic catheter is used for angiography, pressure monitoring, oxygen saturation monitoring. Angiographic catheters can be flush catheters or selective catheters. Flush catheters, example like pigtail catheters, there is no selective cannulation of the vessel. So contrast injection through multiple side holes, uniform injection without recoil. Tip is usually rounded to avoid entering into the vessel and to keep shaft in the center. It do not cause injury to the vessel because of the pressure. Selective catheters like preformed coronary catheters, which are Judkins catheters, they are used for selective cannulation of a vessel. So they have enough flexibility to advance into the vessel, and the rotational stiffness is enough to selectively seek a vessel orifice. Flow rate is not important as contrast volume is less. Around 4 to 6 ml is used per fluoro. So coronary catheters can be diagnostic, can be guide. Diagnostic catheters, as we see, blue catheters, depicted in the diagram by the blue diagram. They have thicker shaft, internal diameter is smaller, they have tapering tips and less reinforced structure. They are made up of 2 layers only. So guide catheters, they are thinner shaft, internal diameter is larger, so that we can pass the guide wires, balloons and stents through the guide. They have non-tapering tips and more reinforced constructions. They are made up of 3 layers. Ideal characteristic of a catheter, it should be better torqueable, pushable, flexible. They should be trackable and should have a atraumatic tip, low surface frictional resistance, and should be kink resistance. Torqueability is increased by increasing the outer diameter and more reinforced construction. By increasing the outer diameter, stiffer material used, and decreasing the overall part length, we can increase the pushability. Flexibility of a catheter is increased by decreasing the outer diameter and increasing the overall part length of the diameter. These are the parts of a catheter. First is the tip. Tip should be atraumatic tip, and more the increase the length of the tip offers more stability in a target vessel, but we cannot maneuver more in the if the tip is more larger. It has a primary curve which depend upon the angle of the target vessel from its parent artery, secondary curve which depend upon the width of the parent vessel, tertiary curve, normal curvature of the parent vessel, and a catheter lengths are usually 100 and 110 cm. Overbent and underbent catheters. Overbent catheters, they have angle of the catheter tip is smaller outside the body than inside. So shape of the overbent inside the body is easy to predict and easy to manipulate. Underbent catheter, they have angle of the catheter tip is larger outside the body than inside. They are difficult to manipulate and shape is difficult to predict. Like Emplart's catheter, they behave very irregularly and they can cause dissections. So they are more prone for injury. Size measurement. The French catheter scale is commonly used to measure the outer diameter of the guide catheters. Most commonly, diagnostic catheters are used 5 to 7 French. There is color coding of the diameter, like 6 French is green in color, 7 French is orange in color, and 8 French is purple in color. So for each given size, internal diameter is either standard or large depending upon the company. So these are the various size internal diameter according to the companies like Launcher, Cordis, Mach 1, Viking catheters, and Weiss guide catheters. So outer diameter is depend upon the French size, which is roughly calculated by French divided by 3. Various French catheters have passability of the catheters through it. 5 French allow balloons of less than 5 mm, stent of less than 4.5, and we cannot do a kissing balloon on 5 French catheters. 6 French catheters, all coronary balloons or coronary stents are passable, and we can use rota up to less than 1.5, and guideliner can be used with 6 French also, and for 7 French, rota bar of 1.7 mm can be used. Guideliner and trapping balloons can be used, and we can do a simultaneous kissing stenting also, like in DK Crush. An 8 French catheter, we can use rotabur up to 2 mm and mainly used for the trifurcation stentings. Catheters are mainly made up of dacron, nylon, polyvinyl chloride, Teflon, fluoropolymers, polyurethane and silicon. The radio opacity of the catheters is incorporated by incorporating barium, bismuth, iridium. This diagram depicts the guiding catheter structures made up of 3 layered construction, while diagnostic catheters, they are made up of 2 layered constructions. Outer layer is lubricious and non-thrombogenic in both of them. Middle layer is braided in case of guide. So it is braided with stainless steel, and inner layer is made up of Teflon. These are the diagrams depicting the braiding of the guiding catheters. Outer layer is done to prevent the friction and reduce the thrombogenicity, should not be thrombus forming. And reinforcement is usually done by stainless steel braiding. The more the flexible part will have a high density of braid pitch, and the stiffer part will have a low density braid pitch. Thick walled catheters, they are better pushable and torque transmissible, but they accentuate the pressure waveforms. They cause systolic overshoot and diastolic dips. As compared to thin walled catheters, they improve monitoring, blood sampling, flushing abilities and decrease thrombogenicity. But they have disadvantage of less torqueable, not suitable for high pressure injections. Proximal push zone has a high stiffness. Distal tip is soft and flexible. So they have a variable differential stiffness according to the area. So tip should be having a less stiffness. Tip and hub. Tip is tapering tip for diagnostic catheters, and hub metal or plastic. They are larger than the catheters. They have tapered hubs for easy insertion of the guide wires or any stents. Side hole catheters have an advantage of prevent catheter dampening, occlusion of the coronary ostium, allow additional blood flow out of the tip to perfuse the artery. They avoid catastrophic dissections in the ostium of the artery and avoid disengagement during forceful injections. But they have disadvantages like false sense of security, because now the aortic pressure and not the coronary pressure is being monitored. They cause suboptimal opacification and make catheter tip weak, kink at the side holes. So for left coronary, Judkins left and Implar's left. For right coronary, Judkins right, Implar's right and right coronary 3D. And universal catheters are multi-purpose Sones and Castillo for the femoral approach. For the universal radial approach, Tiger, Jackie, Kimney catheters can be used for both the right and left coronaries. For the graft, we use JR4 most commonly, and right coronary bypass, left coronary bypass catheters, and various IMA catheters. So catheter choice and size depend upon the access, whether it is radial or femoral, because in the radial we have to take 0.5 less as compared to the femoral in case of JL. Height, as the patient is tall, we have to use longer catheters of 110 cm or 125 multi-purpose according to the height of the patient. Age, anatomy of the aorta, whether it is short aorta, long aorta, tortuous aorta, and target vessels, whether it is left or right coronary, native coronary versus post CABG, whether it is an ACS and elective. So catheters for the native coronaries. Melvin Judkins in 1961, he first developed preform catheters, JL and JR. They are designed for the femoral route. They are tapered tip with end holes. Little manipulation is needed if used from the femoral route. The distance between the primary curve and the secondary curve determines the curve length. So sizes comes from 3.5 to 6 by most companies, and length is around 100 cm. 4 to 7 French is available. Size 4 is most commonly used. Judkins guides have a JL guide has primary curve of 90 degrees, secondary curve of 180 degree, tertiary of 35 degree, which fits aortic root anatomy. As primary curve is fixed, it intubates small segment of the ostium, so it decreases the risk of trauma. Engages the left main ostium without much manipulation. Judkins right size depend upon the width of the ascending aorta, location of the ostia to be cannulated, and orientation of coronary artery segment proximal to the target lesion. Segment between the primary and the secondary curve, which is the curve length, should fit the width of the ascending aorta. The first diagram is showing the proper fit, as it is have a proper fit for 45-degree angle at the primary curve and buttressing against the contralateral wall. Second diagram is an improper fit, as it is too long catheter. We have to downsize the catheter size. And third is also showing improper fit of the JL, and it is too short catheter. We have to upgrade the size of the catheter. Normal aortic width is 3.5 to 4, and less than 3.5 is narrow aortic width, and more than 4 is dilated aorta. Limitations of Judkin catheter, as primary curve is fixed, may not be coaxial with the artery. So it is difficult to pass balloons, as the catheter make an angle of 90 degree with the ostium. JL point of contact on the ascending aorta is very high and narrow, so it increases the chance of prolapse and dislodgement. In JR, there is no point of contact on the ascending aorta, so it provides extremely poor support and is not recommendable for the Shepherd-Crook RCA. Emplart's catheter, it was originally catheter developed by the Kurtz Emplartz, who is an Australian radiologist in 1967. AR and AL comes in various sizes. AL come also in 0.7 size, 7.5 size. It also has a primary and secondary curve. AL 1, 2, 3 depend upon the curve length, distance between the primary and secondary. AL for the RCA we use AL1. For LCA, left coronary artery, we use AL2, and for the venous graft we use AL2. AR catheters are used for RCA for AR1 and 2. The Emplart's guide. Secondary curve rests against the posterior non-coronary cusp, offers firm platform for the advancement of device. Best in case of short LM with downgoing left circumflex artery, and tip point slightly downwards, have a high danger of osteal injury causing dissections. Emplart's guides are very prone for causing dissections. If tip of Emplart's guide does not reach the ostium and keep lying below the ostium, then the guide is too small. If the tip lies above the ostium, the guide is too large. When the RC ostium is very high, left Emplart's AL is used to engage the right ostium. The Emplart's guide, the selection of the proper size is very essential, as it prone for more dissections. So size 1 is used for small aortic roots, size 2 for the normal, and size 3 for the larger roots. Attempt to force full engagement of the Emplart's guides will increase the risk of complications. Emplart's left used for coronary ostia out of conventional Judkins, like high or posterior origin of the coronary ostium. It can selectively cannulate LAD or LCX if short left main stem. So it is useful for the separate origin of LAD or LCX. High anterior right coronary or Shepherd-Crook RCA, we can use Emplart's left. So this is a diagram depicting the how to engage and disengage the Emplart's catheter, as it is very prone for causing dissections. While engaging the left coronary, pushing the catheter will cause disengagement, and pulling the catheter will cause deeper engagement. So we have to be aware while disengaging the catheter. We don't have to pull the catheter directly, we have to push down so it come out of the ostium, and then we have to pull it down, because it is more prone for causing osteal dissections. Emplart's right is mainly used for RCA with an inferior or high anterior origin of the ostium. Long tip catheters like XB or EBU, they have an advantage of coaxial intubation, better support and stability, lack of bends, so improve advancement of devices, decrease the loss of supportive forces. It is much safer. Extra backup EBU guides, their long tip forms a fairly straight line with the left main axis or the proximal ostial RCA. They have long secondary curve which abuts the opposite aortic wall. So tip in the coronary artery is not easily displaced, so it provides a very stable platform. Backup support can be of 3 types: passive, active and balanced. Passive support, strong support is given by the inherent design of the guide with good backup against the opposite aortic wall. Stiffness depends upon the manufactured material. Additional manipulation is generally not required. And it is passive support given by the Emplart's wire. Active support is typically achieved by manipulation of a guide into configuration so it conforms to the aortic root, and deep sitting of the guide is done by the mainly for the RCA, intubation with the deep engagement of the guide into the coronary vessels for active support. Balance support depend upon the inherent property of the shaft and the shape of the coaxiality for the coaxiality, but can be manipulated in case requiring extra support by EBU and Judkins catheter. Multi-purpose catheter. Initially, multi-purpose catheter by UNMICRC and King was developed in 1974. It was developed to avoid the need of 3 catheters for right coronary, left coronary and ventricography for different catheters. So it decreases the exchange time. So it is a single curve with a straight tip and end holes. It can be MPA 1, 2, MPB 1 and 2. A and B depend upon the curve. A is more straight tip 120-degree angle, but MPA B is having a gradual 90-degree curve. And 1 and 2 depend upon the side holes. All are having an end holes, but if it is MPA 2, then there is 2 side hole additional. So they are used for CAG both native vessels and graft vessels, ventriculography, right heart catheterization. With more specialized catheterization, his purpose is reduced. Other catheters like Arani catheters is used for Shepherd-Crook RCA. It is a double angle 90-degree curve which sits on the ascending aorta in S configuration as depicted in the diagram. So it is therefore useful for the RCA with horizontal takeoff or Shepherd-Crook RCA. 3D right curve. 3-dimensional right curve is used for tortuous band anatomy and posterior support takeoff, superior takeoff of the RCA. Coronary ostial locations can be high, low, anterior and posterior. Coronary ostial orientation takeoff can be superior, horizontal, inferior and Shepherd-Crook. These are the common takeoff or of the ostium from the left coronary artery, horizontal, inferior and superior as depicted in the diagram. Common takeoff from the right coronary artery, horizontal, inferior and superior. So inferior multi-purpose guide is properly used, and for the superior also we can use multi-purpose or Amplatz catheter. This is a Shepherd-Crook takeoff of the RCA. RCA origin is not only superior oriented but also courses superiorly to some extent before making a U-turn. So JR guide do not provide proper support to the Shepherd-Crook RCA. For the short and long LMCA, if the LM is short and there is no acute angulation between the LAD and LCX, then left Judkins is preferable. If the LM is long and the angle between the LM and the LCX is acute, then extra backup guide is used, EBU guide is used. For RCA intervention, usually JR or hockey stick guide is used. If extra support is needed or CTO like CTO and tortuosity, then AL guide provides better support. Abnormal takeoff of the RCA from the aorta, especially inferior orientation, then multi-purpose guide is used. Tortuous or band anatomy, posterior and superior takeoff of the RCA, then 3D right curve catheter is used. For the Shepherd-Crook deformity of the RCA, Arani 75, Amplatz, L-gamma, hockey stick, right voda catheters are used. JR is avoided as it do not provide any support. Guides for coronary anomalies. Important to be aware of the variations of the coronary anomaly. If we do not find RCA in the right cusp, then we have to look further in the left cusp. Systematically search in the other sinuses when the vessel is in the question does not arise. For the anomalous arteries arising from the right sinus, like LCX arising from the right sinus, then we have to use left and right Amplatz or multi-purpose catheters. Anomalous artery from the left sinus, like RC arising from the left coronary sinus, then we can use larger left Judkins like 5 and 6 size, left Amplatz and multi-purpose catheters. So guide for anomalous coronary arteries arising from the left sinus. When the RC arises from the left cusp, usually it is anterior and cephaloid to the left main. So JL with secondary curve with one size larger than one used for the left main intervention is used for the RC intervention. Or we can push deep in the left sinus, causing it to make an anterior and cephaloid U-turn. Larger curve will prevent the guide to engage the left main. So summarizing the guide catheters for various anomalies, like for RCA, if it is normal origin and course, then JR4, anterior ectopic origin, then AR, AL or hockey stick, inferior ectopic origin with inferior course, or whether superior ectopic origin from ascending aorta with inferior course, multi-purpose guide is used. For the superior course of the RCA, internal memory, IM catheters or 3D RC. For the tortuous band anatomy, posterior takeoffs, 3D RC. Anomalous RCA from left sinus, then we can use JL5 and 6, which is higher than the left main, hooking the left main, and AR2 and 3 which are larger, primary and secondary curve, distance between the primary and secondary curve is larger as compared to the previous one. So for left coronary, normal origin and course, we use JL4. For large ascending thoracic aorta, we have to use larger size like JL5 and 6. For the small ascending thoracic aorta, we have to use JL3 and 3.5. For anomalous origin from the right sinus, LCA, AR. For anomalous origin of left circumflex from the right sinus, we can use JR, AR, Platt's right, and multi-purpose catheters. For the separate origin of LCX and LAD, we can use AR, AL both. Now coming to the radial axis, radial axis have an advantage of less bleeding and vascular complication. It is cost effective, patient preference as get easily discharged patients, and anticoagulants can be continued during the procedure, but had a disadvantage of more learning curve, more radiation to the operator, and limits guide catheter size. So radial axis, course of the catheter, right radial have a 2 point of resistance, like first in the right subclavian artery and other in the junction of the ascending aorta with the innominate artery or brachiocephalic artery. And as compared in left, there is only 1 point of resistance at the origin of the left subclavian artery from the arch of the aorta, and from femoral artery only 1 point of resistance. So there is 2 point of resistance in right radial artery. This is a diagram showing difficult passing to the aorta because angle is very acute. As on deep inspiration, the angle increases and we can easily able to pass the wire. So universal catheters for the radial artery are Tiger catheter, Jackie, Kimney catheters. They have advantage like they have exchanged, they do not need to be exchanged. They have less fluoro time and less dye should be used. For disadvantages is learning curve is peak and learning curve, coaxial engagement is difficult, increased osteal trauma. In inferior takeoffs, deep sitting and selective conus branch cannulation can occur. So Tiger and Jackie catheters, they are universal catheters. They limit catheter exchange, they shorter procedure and fluoroscopy time and lower cost per procedure. They have Tiger have a one side hole and Jackie catheters have two side holes. They avoid intimal dissection during injection in non-coaxial engagement and prevent kicking of the during injections. They are available in 5 and 6 French sizes and most commonly used for transradial diagnostic procedures. This is a diagram depicting the Tiger catheter with one side hole coming in the size of 4 and 4.5 with a length of 100 and 110 centimeter. And the main problem is selective cannulation of conus branch and it is rarely coaxial. Jackie catheters has two side holes of size 3.5 and 4, length of around similar to the 100 and 110, similar to the Tiger catheter. Platt's type tip because it more prone for injury. So, but have better cannulation and can be used for ventriculography also. Coming to the post-CAB patient, we have to tackle with the Lima grafts and venous grafts. So, commonly used catheters for the bypass graft, we use JR catheters, coronary bypass catheters, multi-purpose catheters, MPA 1 and 2, and L-gamma catheters, hockey stick, and various internal memory catheters. Coming to the how the grafts are positioned on the ascending aorta. Usually anterior surface higher up from the sinus of Valsalva are chosen. Left coronary grafts like for LAD, diagonal, LCX, left anterior surface with circumflex grafts is higher up is positioned. In this diagram, the B is used for LAD and C is used for diagonal and D is for LCX, OM and ramus. So according means LAD is positioned downside and D is for the LCX. JR catheters are mainstay in the graft NGOs. So we have to remember the positions of the respective coronary arteries in the ascending aorta. Bypass catheters like RCB, it's similar to the JR4 with tip curve of more than 90 degree. Left coronary bypass have similar curve to JR4 90 degree, but secondary curve is more acute 70 degree. Lima for the Lima, normal origin of the Lima and Lima, we can use JR4 or internal memory catheters. If the Lima origin is from vertical portion of the subclavian artery, then JR4. If radial, and then left radial approach is more suitable in patients with Lima grafts, as we can easily encroach over the Lima artery. If both Lima is to be cannulated, then JR4 can avoid catheter exchange and can be used for both. Internal memory catheters Resembles Judkin's right except for the tighter primary curve. They have 80° and longer tip. Other catheters for Lima-Rima is barbecue and Rima catheters. Catheter selection for the right grafts. Primary choice is multi-purpose JR catheters, RCB and AL catheters. For the left grafts, left side of the grafts, for the LED, diagonal and LCX, we use JR4 or AL1. Upward trajectory may require left coronary bypass catheters, internal memory catheters, hockey stick catheters. Or more anterior origin, we can use AL, HS, hockey stick and left coronary and multi-purpose. So summarizing the post-bypass graft approach, how can we approach? If only Lima graft is there, then we can use left radial artery. If both Lima and Rima, then we can use right radial or femoral. If both Lima, Rima and radial artery as a graft, we can go by femoral approach. For the Lima and SVG grafts, left radial approach is better. If only venous graft is there, then right radial or left radial both can be used. Coming to the guide catheter exchanger, catheters like GuideLiner, GuideZilla, they based on the concept of mother and child technique, meant for delivery for the hardware down the coronary, and they have difficult tracking in case of difficult trackings. They provide more support. They have come in the length of 145 cm, which having a 25 cm guide catheter segment and 120 cm proximal hyposhaft tube. So internal diameter is 1.45 mm and outer diameter of 1.68 mm. So conventional JR guide has less support because it has limited support from the contact with the opposite aortic wall. So they usually disengage. So guide catheters back out. Resistance to the stent passage causes back out, guide to back out. Backup is lost as guide comes away from the coronary ostium and aortic wall. As we pass the stent or any balloon through the proximal lesion, the guides come away. So we need mother and child technique for this, and for deep engagement, we have to use guide catheter exchange. So they provide shape change of the guide. They shape change of the R4 into Emplart's left shape. So it increases the contact with the aorta and increases the support. And deep intubation increases the contact within the coronary artery also, and provides a great increasing support. And we can easily pass the stent and balloons through the guide extension catheters. How we deploy the guide liner? Guide catheter position at the ostium of the RCA. Tip of the guide liner is deployed into the RCA. Up to 10 cm we go, and guide liner is advanced distally up to 10 cm into the vessel. Now we can use the stents for DC deliverability, and guide will not push as it acquires the shape of Emplart's. Coming to the coronary microcatheters. Purpose or uses of the microcatheter is additional guide wire support and lesion crossing. Lesion in case of bifurcation and distal lesions in CTOs, exchange the guide wires and injecting the radiopaque contrast material. So guide wire support and lesion crossing. Microcatheter, as we see the first diagram, run through guide wires is passing through the lesion. It has a tip load of 0.6 gram. As we pass the run through guide wire through the microcatheter, it becomes 10 times, and it tip load of 6.1 grams. So they provide support and easily lesion crossability because of the high tip loads and easy supportability. For distal lesion assessment, in this diagram we are showing CTO is RC CTO is crossable through the septal branch, through septal approach. So they provide easy lesion access through in CTO lesions. For bifurcation lesion, a microcatheter helps to prevent guide wire prolapse and provide support and direction to the guide wire to enable to access to the bifurcation. Guide wire exchange, we are doing any passing wire through the CTO, like pilot 50 is used, or 150 is used, or crossover wires is used. So for exchanging these hydrophilic guide wires with the workhorse wire, we can use the microcatheters. And for the injection of the contrast dye. So difference between the fine cross and Corsair microcatheters. Fine cross is made up of stainless steel braided construction, while Corsair is made up of tungsten braiding with Shinga shaft. Shinka shaft means variable braiding technology. So the diameter of fine cross is approximately 2.6 and distally 1.8, while Corsair is having a larger proximal 2.8 and distal is also around 2.6. Both are having inner layer of PTFE, but fine cross is having a 13 centimeter extra floppy segment, and Corsair it comes a 1.3 French extremely soft tapered tip. So this is a diagram depicting the Corsair microcatheter with a tapered soft tip, Shinka technology with variable braiding, and hydrophilic polymer coating with tungsten braiding. So advantages of fine cross is they have overall lower crossing profile of 1.8 French, which allow easy crossing of the tight lesions, and it has a 13 centimeter floppy distal segment which is more flexible than Corsair, so allow good trackability through bifurcations, and has a great push for effective crossing of the complex lesion. But Corsair is preferable in CTO lesions as it has 1.3 French entry profile for probing micro channels of the CTOs. They have larger diameter of 2.8 and 2.6 proximal and distal respectively, so a stiff proximal segment for pushability to reach distal places in the anatomy in case of retrograde approach. They have Shinka shaft with variable braiding on the shaft, providing a dilating effect for the septal vessels in retrograde CTO approaching the RCA through septal branches. So for complex lesion, fine cross is a better choice. For CTO lesion, Corsair is a better choice. For bifurcation lesion, we can use both microcatheters. Asahi Caravel, they have a low profile of tip which tapers to 0.48 mm. They have excellent crossing profile, and they have excellent tip flexibility which improves the tracking. They have unique braiding, delivers flexibility without compromising the internal lumen diameter, and maintains optimal guide wire performance. They have flexible tip which provides superior trackability. There is smooth transition with subtle changes in the flexibility from flexible tip to the shaft, so the Caravel tracks well around an acute bend. So Caravel for the PCI, for a complex PCI, antegrade cases and retrograde cases, Caravel is very good, and it is easy to advance and just push. We have to just push this. An excellent crossing profile, and braided wires maintain lumen diameter and guide wire performance. So conclusion is guide catheters form the backbone of any intervention procedures. If guide is not good, we can't continue our procedure and cannot finish the procedure without any complications. So guide catheters should be chosen properly. Adequate guide support is very important for smooth and fast procedure. Different guide catheters have different properties which we have to look for and suited for different scenarios. Special catheters are available for the extra support and abnormal ostium. So guide catheter extensions help to overcome problem of trackability and support in difficult anatomy and tortuous lesions like Shepherd-Crook RCA. Thank you.